Welcome, everyone. My purpose here is to discuss additional pearls in nephrology for the Intensive Review of Internal Medicine course 2020. I'm Ajay Singh. I'm the physician in the renal division of the Brigham and Women's Hospital and Senior Associate Dean for Postgraduate Medical Education at Harvard Medical School. I'm also the director of the IRIM course. This is my disclosure slide. We're going to discuss four scenarios. First is on chronic kidney disease anemia. Second is on chronic kidney disease in a patient who is hyperkalemic. Third is a patient with autosomal polycystic kidney disease. And the fourth is a patient with kidney stones. In our first case, this is a 62-year-old white woman with a 10-year history of CKD from diabetes. She has slowly worsening renal function. Past medical history of a right CVA stroke. She sees you in the office. She feels great. She's been working, exercising, and eating well. Her lab data shows a BUN of 48, a creatinine of 4.2, an estimated GFR of 18, a hemoglobin of 9.1, TSAT of 30%, and a ferritin of 282. The questions this case raises, number one, should she be treated with an ESA, an erythropoiesis stimulating agent? Two, what target hemoglobin level should you be aiming for? Should it be normalizing the hemoglobin, or should you be treating her to a subnormal hemoglobin level? And thirdly, what do we think about her iron stores? And is she iron replete, and are we comfortable with that? So this summarizes the state of the art on anemia treatment in dialysis and non-dialysis patients. In general, the target range for patients in the United States who have chronic kidney disease, whether they're on dialysis or not on dialysis, is a hemoglobin of 10 to 11 grams per deciliter. And this guideline that has been disseminated by the FDA has been around for at least a decade. And so it really supports the idea of not normalizing the hemoglobin. And it arises from studies that suggest that there's an increased risk, especially with respect to cardiovascular outcomes with normalization of the hemoglobin, and we'll review some of that information. You want to make sure your patient is iron replete, so you want to look at the patient's TSAT. Remember, TSAT is a derived estimate of iron deficiency. It is the serum iron over the total iron binding capacity, and that gives you a percentage. And the guideline says the percentage should be greater than 20% in patients with chronic kidney disease to call them iron replete. Ferritin, which is both an acute phase reactant but also an indicator of iron stores, the guideline says it should be greater than 100 nanograms per mil. Number three, the use of an ESA is recommended in patients who are anemic or iron replete, particularly if they're symptomatic. Currently, there are a number of different ESAs on the market, but the two most prevalent in use are Epoetin alpha or Epogen, or marketed as Procrit in the United States for non-dialysis patients, or Darbepoetin. The other high-level message in the treatment of anemia is that one should be cautious of using ESA treatment in patients who have a history of stroke and/or cancer. And this is based on the TREAT randomized control trial, which we'll discuss in a minute. So these four things are things you need to take home as the current state of what our knowledge is. Now, the TREAT study was a very important study that was published in the New England Journal of Medicine in 2009 by Mark Pfeffer and colleagues. This was in a population of patients who had chronic kidney disease and who were diabetic. And patients with anemia were recruited and either placed on Darbepoetin alpha, the ESA here, or placebo. In those patients targeted or treated with Darbepoetin alpha, the goal was normalization of the hemoglobin, 13 grams per deciliter or above. And in the patients treated with placebo, the goal was to keep them at a hemoglobin above 9 grams per deciliter. And this trial, a double-blind randomized control study, looked at two composite outcomes: a cardiovascular composite, which is shown on the left-hand side of the slide, and a renal composite shown on the right-hand side of the slide. And what you can see is that these Kaplan-Meier curves are essentially superimposable. There's no benefit with respect to cardiovascular composite, the cardiovascular composite endpoint, or with respect to the renal composite endpoint with treatment with darbepoetin. So the real question is, what's the benefit of treatment of anemia? Well, the answer is the benefit of treatment for anemia is not on hard endpoints such as cardiovascular or renal. I think the real benefit of treatment for anemia is whether you can actually improve quality of life, make patients feel better, make them less fatigued. And so in our case that I cited in the prior slide, this patient was doing fine. She was exercising, she was feeling good. So treatment of anemia really would not be ordinarily necessary. The other point that came out of the TREAT study was the increased risk of stroke, both fatal and non-fatal, among patients treated with darbepoetin. So among those patients treated, there was a nearly twofold increase risk of stroke with treatment as compared to treatment with placebo. And very importantly, the risk of stroke doubled among patients on an ESA who'd had a prior stroke. Now, as you recall, the study population were patients with diabetes, with chronic kidney disease who had anemia, and this finding has not been generalized to other subsets of patients. So this finding has not been replicated, for example, in non-diabetic patients. But it is certainly something to give you pause with respect to treatment, especially among patients who already have a history of stroke. In a study that was published 3 years prior to the TREAT study, which I was the first author of, the QUIRE study, this was a study on non-dialysis chronic kidney disease patients. And it was a open label study where treatment occurred or was used in both arms. So patients were treated in both arms with epoetin alpha. In one arm, the goal was to increase the hemoglobin to 13.5 grams per deciliter, and then the other arm to keep the hemoglobin at 11.3 grams per deciliter. And you can see that when you looked at the composite cardiovascular endpoint of death, MI, CHF, and stroke, that there was a higher risk in trying to increase the hemoglobin using ESA versus in controls. So you can see about a 33% higher risk of increasing the hemoglobin to near normal ranges at 13.5 grams per deciliter compared to 11.3 grams per deciliter. When you look at the components of this composite endpoint, what appeared to be driving this increased risk was death. There were 65 deaths, and there was a significantly higher rate, nearly 50% higher rate of death in those patients in whom a higher hemoglobin was targeted. There was also a higher rate, but it was not statistically significant, a higher trend of CHF hospitalizations, but no difference in stroke or myocardial infarction. So the QUIRE study suggested that normalization of hemoglobin using an ESA is associated with increased risk, whereas the TREAT study showed that there was no increased risk, but there was certainly no benefit. And so these two studies taken together suggest that there is really no benefit, and potentially there is harm with normalization of the hemoglobin in patients with chronic kidney disease. What are the different types of agents? Well, as I mentioned at the very beginning, by far there are two agents that are used in most patients with kidney disease in the United States. Epoetin alpha, which was approved in 1989, and it's a short-acting ESA. It can be used both IV and subcutaneously, but you need to reduce the dose when you use it subcutaneously. And it's approved to be used in dialysis patients 3 times a week. Darbepoetin, which was launched and approved in 2001, has a 3-fold higher half-life and can be given once every once to 2 weeks, and can be even given even less frequently than that. Okay, so now let's discuss the second topic. This is a 44-year-old patient with chronic kidney disease who has a potassium of 7.2 milliequivalents per liter. She's a woman who has stage 4 kidney disease. Her serum K of 7.2 milliequivalents per liter is noted on lab values, but she denies nausea, vomiting, and diarrhea, and she has no new medications. Physical exam, her weight is 72 kilograms, her blood pressure is 141/62, heart and lung exam are normal, and she has no edema. Her EKG is shown on the next slide, and you can see here, this is her actual EKG, and you can see the limb leads and the precordial leads. And what's evident, particularly in the precordial leads, is the tenting of her T waves, these tall peak T waves. There's also a loss of her P wave and some widening of her QRS. So this summarizes the electrocardiographic changes of hyperkalemia, and you really do need to know this in order to manage patients like this. So just to summarize, hyperkalemia associated with peak T waves or tenting of the T waves, a P wave that's wide and flat, prolongation of the QRS interval with bizarre QRS morphology. You can sometimes see high-grade AV block with slow junctional and ventricular escape rhythms, a conduction block, which can manifest as either a bundle branch block or as a fascicular block, and as a pre-terminal rhythm, the development of sine wave periods. And certainly this last feature or abnormality is not something you want to be seeing because it's often a prelude to ventricular tachycardia or ventricular fibrillation. Causes of hyperkalemia are shown in this next slide, and they can be listed or broadly characterized as an increase in intake, a decrease in renal excretion, intra to extracellular shifts, and artifactual. The most common causes of hyperkalemia among patients with kidney disease tend to be increased intake because they're not excreting potassium. So anything they take in, if that potassium is absorbed from the foods they eat, can result in hyperkalemia. Obviously, in patients with kidney disease, reduced renal excretion can be a source of hyperkalemia. And in patients with kidney disease, drugs such as potassium-sparing diuretics, spironolactone, triamterene, amiloride can also be important causes. And of course, always added to that list are non-steroidals. Adrenal insufficiency can also be an important cause, but it's not common. Intra to extracellular shifts are seen, and you should be cautious of detecting this because sometimes you can overtreat or overestimate the degree of hyperkalemia if you don't take into account these shifts. So hyperosmolarity, insulinopenia, so in a patient who's got diabetic ketoacidosis, for example, where you have both a lack of insulin and some increase in osmolarity because you've got a very high blood glucose, you can see an extracellular shift with hyperkalemia. Metabolic acidemia, again, there's a shift, and medications such as beta blockade. Artifactual is important, again, something that you should detect, particularly in vitro hemolysis for a sample that's been lying around for too long, leukocytosis, thrombocytosis. And then pseudohyperkalemia is a cause not seen very commonly. So what is the management of hyperkalemia in a patient who's in the ambulatory setting? And I like to divide this into 3 categories based on the level of potassium. A potassium of less than 5.5, potassium between 5.5 and 6, and a potassium greater than 6. Among patients with a potassium of less than 5.5, especially in those patients without any evidence of structural cardiovascular disease, or in patients who are chronically on the high side with respect to their potassium, this might be a chronic dialysis patient, or a patient with chronic kidney disease who comes in constantly with high normal potassium, or in then the treatment there is really to hold the potassium raising medication. So you want to be conservative. You might want to recheck, bring the patient in for a recheck in the laboratory. The situation is different if the patient has structural cardiovascular disease. Here, the recommendation would be do an electrocardiogram, hold any medication that raises the potassium, an ACE inhibitor or an ARB, consider a dietary restriction, tell the patient to avoid tomatoes, oranges, avocados, beans, and so on, and consider treating the patient. And we can talk about treatment in a few minutes. In patients with more moderate hyperkalemia, the recommendation would be do an electrocardiogram. So if you just get a call from a patient, what would you do? You'd say, I want you to go to the emergency room or come into my practice and we'll do an EKG on you. In the interim, tell the patient to hold any potassium raising medications, ACE inhibitors, ARBs, that thing, and treat the patient. In a patient with more severe hyperkalemia, really the goal here is emergency treatment. You want to do an electrocardiogram, usually in an emergency department setting, particularly if the potassium is much higher than 6. So if it's 7 or 7.5. If there are EKG changes like the ones we discussed, where there's tenting of the T wave and flattening of the P wave, and especially if there's widening of the QRS, you might want to treat the patient with a cardioprotective medication such as intravenous calcium gluconate, and then come in with a cycle of insulin, dextrose, and then potentially use an agent to bind the potassium that's in the GI tract and prevent its absorption. You may want to consider dialysis. In a patient, of course, who comes in with a high potassium but doesn't have EKG changes, then you want to recheck the potassium. You may still want to treat the patient with insulin, dextrose, and some sort of binding resin, but you'll recommend dietary restrictions. So you're a little less charged up in order to institute more emergent treatment. This next slide summarizes the treatment of hyperkalemia. And so we did discuss some of this already. So the mechanisms are shown in the left column. Stabilizing the membrane potential, you would use calcium for that, and the doses are provided. To push the potassium back into the cells, you'll use insulin with dextrose to cover the insulin that you're providing. You might consider beta-2 agonists, such as nebulized albuterol. And then for potassium removal, there are various options such as K-exalate, ZS9, and of course, hemodialysis, and we'll discuss that in a minute. What you can see on the right-hand side is the time of onset. So calcium is going to work very quickly. Insulin is going to take about 30 minutes and will last for 2 to 6 hours. And then some form of binding will take hours to work. Hemodialysis, of course, has effect immediately. As you place the dialysis, a patient on dialysis, you're going to remove potassium immediately. Now, ZS9 is an inorganic cation exchanger, which is new, and it has a high selectivity for potassium. It binds 9 times as much as potassium, binds 9 times as much potassium as K-exalate, which is an organic polymer resin. ZS9 comes as a fine powder that dissolves in water and is tasteless. And more now we're using these newer forms of potassium binding resins rather than K-exalate. So this slide compares K-exalate, SPS, Pitormer, and ZS9. And I'm not going to go into the details. The slide is going to be available for you to look at in more detail. But the key issue really is with respect to their use is with safety and tolerability. Both Pitormer and ZS9 are much better tolerated and much less likely to be associated with significant morbidity. Whereas K-exalate, which has been around for decades, increasingly has raised concerns around colonic necrosis and various electrolyte disturbances. And it's usually fairly poorly tolerated. So this just focuses on the issues with K-exalate. Ischemic colitis and colonic necrosis are the main issues. The risk is much higher in patients who are administered the enema form. Once patients get, or if they get ischemic colitis, the complication is often fatal. It's not common, but there have been many case reports. The literature suggests there's an increased risk with sorbitol, but it can occur without sorbitol and is associated with intestinal SPS crystals. Remarkably, patients who are post-transplant and patients who are post-op seem to be increased risk. The other issues with KX-late are that can be associated with volume overload, and that's because it contains sodium. The SPSS is sodium polystyrene, so you can cause ECF volume expansion. You can cause a reduction with its use in the serum calcium, and if you use it for prolonged periods of time, it can be associated with hypokalemia. Pitomer is shown here in this New England Journal article to be a very effective binder of potassium and can be associated very effectively with the treatment of hyperkalemia. And so you can see at week 4, 76% of patients who had mild to moderate hyperkalemia reached their target potassium level. And it was not associated with significant adverse events, mild to moderate constipation about 11%, and hypokalemia about 3%. This is a study with ZS9. This was published in the European Heart Journal and is a pooled analysis. These are patients with a potassium of greater than 6. And you can see the key observations are that it is very effective. So green is baseline and in blue is treatment, and you can see it's quite effective in treatment. Many people raise the issue of bicarbonate as treatment, and what I would tell you there is bicarbonate is effective, but it's not effective short term. So here shown is a paper from Blumberg published now many years ago, and you look on the vertical axis, reduction in plasma potassium, 0 being baseline, less than 0.5 milliequivalent, reduction of 1 milliequivalent and reduction of 1.5 milliequivalent. And you see that over a 1-hour period, shown on this horizontal axis, dialysis is the most effective in getting rid of potassium. Insulin dextrose in driving potassium back into the cells. Epinephrine, also important in driving potassium back into the cells. But bicarbonate short-term is not effective. In contrast, when you look at, in the same paper, changes in potassium over a longer period of time, now this is shown over 360 minutes or 6 hours, you see that over this longer period of time, bicarbonate was effective in reduction of potassium, but it was not a huge reduction, but it certainly does work. So the key message out of this is that short term, to protect the heart, you want to use calcium gluconate. You want to use agents such as insulin and dextrose. You want to use a beta agonist. If you really want to remove potassium very quickly, you may want to do hemodialysis, particularly if the potassium is high and there are EKG abnormalities. With respect to longer term removal through binding, there are newer agents that you can use that are effective and associated with lower side effects. Case number 3. This is a 42-year-old woman with a history of autosomal dominant polycystic kidney disease, who's diagnosed in her 20s with a strong family history, who really wants to know about treatments for ADPKD. On physical examination, her weight is 74 kilograms. It's been unchanged from 2 weeks previously. Her blood pressure is 141 over 62 millimeters of mercury. Her heart rate is 82 beats per minute. She's otherwise normal except for some abdominal fullness in the flanks bilaterally. Her BUN is 34 and her serum creatinine is 1.5 milligrams per deciliter. So the real question here is, she wants advice what to do. How do I stay off dialysis, she asks. So let's just review some key facts about ADPKD. It is the most common genetic disease, and its incidence is 1 in 500 to 1 in 1,000 live births. Mutations occur in about 70% of people on the short arm of chromosome 16p. That's the PKD1 locus. About 30% of the mutations occur on chromosome 4, and that is the PKD2 locus. The clinical manifestations are abdominal mass, particularly in patients of more advanced disease, where they really have this protuberant abdomen because of very large kidneys, chronic flank or back pain because they're carrying these 2 large kidneys in them, in their abdomen, gross hematuria, particularly where the cysts ruptures. And this can be quite painful in patients and distressing when they have gross hematuria. Presence of recurrent UTIs that can be challenging to treat because it's difficult sometimes, unless you know which antibiotic to use, and you should be using lipophilic antibiotics, you will not be able to penetrate the cyst and effectively treat the infection. And then the risk of nephrolithiasis in here, the risk of uric acid stones. It is important for you to know that ultrasound is used to both screen and then diagnose PKD, polycystic kidney disease, in at-risk patients. And this is a paper from the Journal of the American Society of Nephrology, now published nearly 20 years ago, and a paper from Ravine published in the Lancet even longer than that. The Ravine criteria, which is shown in the top panel, in patients less than 30 years of age, you need at least 2 cysts to make the diagnosis, and these need to be either unilateral or bilateral. Patients aged 30 to 59, you need at least 2 cysts per kidney. And in patients age greater than 60, you need at least 4 cysts per kidney. And the reason this changes is because there is this increased prevalence of simple cysts that occur in patients when they age, which are completely normal. These are simple cysts. So to distinguish those patients with a simple cyst from those with polycystic kidney disease, you want to have age-based criteria. This paper from Pei suggests that you need 4 cysts in both kidneys for sensitivity of 96%, particularly for the diagnosis of PKD2. The other key message with PKD is that patients' kidney function in PKD doesn't deteriorate in a sort of linear fashion. For many years, regardless of whether you have PKD1 or PKD2, kidney function is relatively stable. And then when the cysts reach a certain critical mass, there is a sudden, abrupt decline in kidney function. So it's stable for many years, but then decreases occur when the kidney volume starts to get much larger, so greater than 1,500 mils per kidney. And so seen here is a paper from 1999 in the Lancet. You see renal survival, PKD1 and PKD2. The other message is that patients with PKD1 progress faster than those with PKD2. So if you see someone who's in their 60s and you say, how come this patient has normal kidney function? There are 2 points. One is it could be false reassurance. They could be, they could reach a point then that they would suddenly have a decline in kidney function. So you have to be very vigilant. And then the second is they could have the less severe version of the disease from a mutation in the PKD2 locus. Treatment of PKD2, these are the important points that you need to take home. One is progressive renal insufficiency. There's lack of proven benefit of either low protein diets or renin-angiotensin system blockade. But there is evidence from papers published several years ago that rigorous blood pressure control in early PKD is effective in slowing the increase in total kidney volume. And remember, kidney volume ultimately is an outcome, because after the kidneys get to a critical mass, you will get this precipitous decline in kidney function. So rigorous blood pressure control does serve to slow increase in kidney volume. But over the period of time these patients were studied in this trial, there was no overall change in estimated GFR. But clearly, the take-home message is that if you want to prevent increase in kidney volume, which in a sense is a surrogate marker for progression, then rigorous blood pressure control, particularly in early PKD, is important. Many of us who see patients with PKD will also recommend to patients a high water intake, and that's to influence the water channel, and there's some evidence that that works. And I recommend patients drinking more than 2.5 liters per day. And then you want to manage the extrarenal manifestations. You want to intervene as needed for symptoms. You want to think about screening patients for cerebral aneurysms, particularly if they have a family history of cerebral aneurysms. And you want to think about antibiotic prophylaxis if they have a history of or evidence of valvular regurgitation. And among patients who have particularly liver cystic disease, you want to avoid estrogen or progesterone, particularly in women. The final topic or case is topic number 4, which is a patient with kidney stones. So this is a 37-year-old man who presents with a 2-hour history of excruciating pain in the left groin. It started in the left flank and was associated with an episode of gross hematuria. And there's a past medical history of right flank twinges. Of physical examination, he looked in pain. He was writhing and sweaty. He had a weight of 72 kilograms, a blood pressure of 155 over 80, a heart rate of 105. And he had some mild tenderness in his left flank, but there was no guarding and no edema. His laboratory data was significant for a creatinine of 1.1, and his urine analysis for the presence of 4+ blood, 1+ leukocytes. But the sediment, while it had lots of red cells, too numerous to count, these red cells were not dysmorphic. And while there was occasional white blood cells, there were no casts. So how do you manage this patient? This is a patient with a suspected kidney stone. You do, what I do is a plain abdominal x-ray. It's useful. If some people believe that a plain abdominal x-ray is not particularly beneficial because there's a high risk of radiation from that, in which case if you have available easily to you an ultrasound, you do an ultrasound. If the patient has a stone, which is radio opaque, then fluid and medications. If the stone is not radio opaque, then probably uric acid. It's a uric acid stone, and you may think of fluid resuscitation, pain medication, alkalinizing the urine, and potassium citrate. In many places, there is no ultrasound available in a timely fashion, and there's concern about using a plain abdominal x-ray. So most people are now gravitating the use of CT, particularly spiral CT. The benefit of a CT is that you can easily document the size of the stone. And if the stone is greater than 5 millimeters, it's not going to pass easily. And in this patient, you want to give them you want to resuscitate them fluid, give them pain relief, and you want to seek urological evaluation. If the stone is less than 5 millimeters, you ask the patient to strain their urine. What do I do with respect to this? I give them, or I ask them to buy coffee filters and try to strain their urine using coffee filters, and then you can discard the coffee filter if there's no gravel or stone. And you continue the hydration. Usually give them also Flomax, which helps to relax the ureteric muscle and potentially help with passage of the stone. And if the stone passes, then you do a renal ultrasound in about 2 weeks to just make sure the hydronephrosis is either cleared and or that there are no other kidney stones present. The scenarios on the left are very common, and one of the things I would recommend is after all of this has been done, you refer the patient to a nephrologist, because what we would then do is an analysis, not only get a stone analysis, the stone is passed, but also do a chemical analysis of the urine to see what characteristics in the urine deem this person to be a stone former. Are they hypocalciuric? Are they hypocitriuric? Do they have too much oxalate in the urine? And so on and so forth. Now, what happens if they have a uric acid stone? You've done the conservative things, you've done the CTs, you see a Staghorn calculus. If that is present, then percutaneous lithotomy plus the use of ultrasound to destroy the stone is necessary. SWAL. If a Staghorn calculus is not present, then based on the location of the calculus, you have to make a decision about using either SWAL or ureteroscopy. Imaging for patients, non-contrast helical CT with a stone protocol is the gold standard in most places. Not everywhere is CT available, emergently. If it's available, use it. If that's not available, use ultrasound. If that's not available, a plain KUB is often reasonable. The advantage of a non-contrast helical CT is it detects stones not visible by KUB and has a significantly better sensitivity and specificity. Most of us have completely stopped using an IVP, an intravenous pyelogram. Ultrasound, particularly for patients needing avoidance of radiation, so pregnant patients, individuals of childbearing age, IVP is no longer favored due to low sensitivity, and there's a higher radiation exposure. A KUB will miss radiolucent uric acid stones. It's probably the most easily available test in a patient with writhing with pain. There is an increased risk of radiation exposure, but it does have a benefit of being easy to do, and it's highly available. But it will miss small stones or stones with overlying bony structures, or when there's gas in the intestine. What happens if stones don't show up on imaging? 85% of stones are radiopaque. They're calcium containing or cysteine containing, and you see them, and you see that picture here. 15% of stones are radiolucent, and these are usually uric acid stones or Indinavir stones. And so that's why it's very important, particularly if you don't see the stone, but everything suggests a stone, to do a CT using the stone protocol. Treatment, we've discussed this. If the stone is less than 5 millimeters, it might pass spontaneously. And so observation, pain control, use of Flomax, straining the urine is important. If the stone is greater than 5 millimeters, refer the patient to urology. Risk factors for stones are shown here. Dehydration concentrates the stone forming constituents, anatomical abnormalities. This promotes stasis, infection, and or crystal adhesion. Changes in urine, pH, diet, and medication, all are important risk factors. Probably the most important risk factors are dehydration and diet, because patients that you see, you can have that, you can modify that. Medications, I don't see that as a common cause of kidney stones, but certainly taking a good history and particularly focusing on family history, on eating habits, and so on is quite important. Just to review this, 70 to 80% of kidney stones are calcium oxalate stones, 10 to 15% are uric acid stones, 10 to 15% are magnesium ammonium phosphate stones or struvite infection-related stones. Less than 1% are cysteine stones. Cysteine stones you're going to hear about more in the boards rather than in real life. So I'm going to stop at this point. Thank you for your attention, and these are the references. Thank you.